What is up? Hello and welcome to episode 118 of Chairside Live. We've got a good episode planned for you today. We've got part one of my interview with Dr. Paul Homoly. I had the chance to sit down with Paul, and he's a very interesting guy. He probably has done more to help my speaking than anybody else I know. I've done training with him as a public speaker from when I go out and lecture, and I've also trained with him to speak to patients. And so it turns out that it's not that different communicating to a crowd as communicating one-on-one to your patients, really for that matter, even communicating with your kids. And he really is a communication expert. And we're going to talk about how to form a relationship quickly with a patient. If you can build up that trust and build up that rapport, the quicker you can do that, the faster the patient will say yes to recommended treatment. In our case of the week this week, we're going to take a look at some Empress crowns that came back a couple times from a dentist. And what he didn't like about these crowns is that you could see the cement showing through the e.max crown. And so we're going to take a look at the possible causes, what could have been done to correct this, and what we're now going to send back to the dentist on this third time, where you can actually see the cement through the crown that he sends back. And it's pretty interesting. Hopefully you'll be able to see it. We going to put it on a darker background. In person, it's clear as a bell. You can see the outline of the preparation of the cement through the facial aspect of the crown. But before we get to that, we've got a viewer mail this week, and it's a question that I've received a couple times lately. I hadn't seen this one for a while, so I thought I'd share it with you. Hey Mike, I've got an interesting case coming up and I wanted your thoughts. The patient is 14 years old and is congenitally missing tooth number 7. Due to her age, I did not recommend an implant in the space for tooth number 7. Our plan is to do a Maryland bridge there, and I'm planning on using e.max as the material. The patient has an open bite, so I'm not concerned with the occlusion on the wings of the Maryland bridge. But I was wondering, should I prepare the lingual surface of tooth number 8 in any way for the wing portion of the Maryland bridge? And should I use my diode laser to create an ovate ponic space for tooth number 7? If so, what technique would you recommend? Thank you, Alex. Well, first thing is, if we're talking about using e.max for a Maryland bridge, it's important that we keep in mind whether or not Ivoclar, who of course manufactures e.max, is okay with this. And I printed up the indications and contraindications for e.max, because this, they've done a lot of testing on this and feel pretty confident about where it's going to work and where it's not going to work. So for example, on their contraindications, posterior bridges reaching into the molar region, it's pretty much always been restricted to the first bicuspid or second bicuspid forward 3 units. Never 2 ponics next to each other. It's not strong enough for that. Inlay retained bridges are contraindicated. So if you were missing a lower bicuspid and wanted to do an inlay on either side, they're saying no to that. Very deep subgingival preparations. That's interesting. That one I would kind of say every material is contraindicated for very deep subgingival preparations, just because you're not going to be able to get a good impression. Patients with substantially reduced residual dentition, so really anterior, severely worn cases where you're going to have to build a lot back up. Bruxism, and of course cantilever bridges, Maryland bridges, and any other uses not listed in the indication. So Maryland bridges are definitely contraindicated for e.max. And so we tend to, just because of product liability and having to do remakes, we tend to stick by the recommendations of the manufacturer, kind of the same way we hope people would do that with BruxZir Solid Zirconia. So if they say not to use it for Maryland bridges, we will not actually fabricate a Maryland bridge out of e.max. But dentists definitely still want the aesthetics of e.max, so our compromise has been to use a lab fabricated composite. Think something like Bell glass, and that would make up the wings. So we'd have the 2 composite wings and then a composite pontic, if you will, that looks like it's been prepared, and then an e.max veneer that gets cemented onto the front of that. So you still get the looks of e.max in the anterior with that nice veneer blending in with those other adjacent teeth. And we have the rest of the framework of the bridge made from a lab fabricated composite. Is that going to be stronger than the e.max? It's tough to say. It bonds better to the back of the teeth, but the fact of the matter is that e.max is in fact contraindicated for the Maryland bridge, so we can't make it out of that. Our preferred way, of course, is to use metal wings, but nobody likes that, including us. But when we do make Maryland bridges, the majority, if not all of them, are with metal wings, with the exception of that composite e.max bilayered situation that I mentioned earlier. BruxZir has been brought up before, and dentists want to know, can I do a BruxZir Maryland bridge? And again, we're just not confident enough in the strength between those thin wings, even with no occlusion there. And I know it seems like that would really take a lot of pressure off the bridge, and it probably would, but we've resisted using BruxZir for Maryland bridges as well. As strong as BruxZir is, at 1.5 millimeters thick on a crown during that hammer test, when it comes to the bridges, we have to have 3 millimeters by 3 millimeters of vertical and horizontal dimension. So it ends up being 27 square millimeters of size between the pontic and the abutment to know that an all ceramic BruxZir bridge is not going to break when it's in function. And obviously with a Maryland bridge, you know, we would be talking about a pontic with 2 little wings much thinner than that coming off it. And so it's just one of those situations where metal is the best answer, which is why I still use some PFM bridges. But Maryland bridges are another indication where, you know, metal is actually just better. But in an area like this, where you've got a patient who won't take metal wings, or you don't even want to try metal wings, that composite resin framework, where you're going to bond that into place, and then you're going to take the e.max veneer and cement that or bond that onto the resin framework, could be a good compromise. And so really the only 2 choices are the metal wings or the composite framework with the e.max veneer bonded to the front of that. So I have the feeling you're going to choose the latter and try it with the composite. Yeah, composite may not be as strong as e.max, but again, as you mentioned, she's got that anterior open bite, and so we should be good with that. So send in that case, if you will, send it to my attention, and we'll get started on that for you. Love it if you would take some before and after pictures too. Love to be able to share those with the viewers at home. So thank you for that. And now let's go ahead and take a look at the case of the week. For this week's case of the week, I saw an interesting one come across my desk. This is an e.max crown that the dentist tried into the mouth and it fit. But he noticed that he could see the cement showing through the facial. You know, you can kind of see the outline. It's a little tougher to catch on camera than it is just with the human eye. But you can see the outline of the preparation basically. And if you look at the inside, you can see that there's a yellowish cement that has been used. So that's part of the reason why it's showing. You know, you could use a translucent cement and you know, have a better result, or there could have been a little more reduction. We were a little short on facial reduction. It was right around 7/10. We'd prefer 1 millimeter, so that didn't show through so much. But it got me thinking, because e.max is so translucent, or can be so translucent, it got me thinking not only about cements, but about stump shades as well. And it would behoove you to let your laboratory know about the stump shade, and perhaps even if you're going to use cement that isn't translucent, for example. And so when you get into bonding, most of the resin cements do have a translucent or a clear variation, which is slightly yellow, as it kind of should be to blend with the dentin. But most crown and bridge type cements, you know, Reliax Luting Plus is white, Ceramer's white. This one appears obviously not to be a resin cement, but it's also yellow. I'm not exactly sure which cement that is. So certainly when you're dealing with translucent restorations and you're making that decision between should I cement this or should I bond this, that might steer you a little more towards a resin-based cement because they do come in translucent. But we've also seen issues with dark stump shades on endodontically treated teeth showing through as well. And even sometimes metal post and cores where the doctor feels like he would really damage the tooth if he tried to remove that metal post and core. So this is one of the impulse ingots of e.max. This is one of the newer ones from Ivoclar Vivadent, and it was really designed for no prep veneers so that it looks very enamel-like. It was basically made to kind of replace enamel, but it also looks very good when it's used in crowns, and I see more and more technicians using it because they really like how it looks, but because of the translucency, this is part of what can happen. And so it got me thinking, well, what would happen if this was done, this same crown? So we're going to take this same crown and go back to the CAD/CAM file and mill this same crown. I'm going to mill 4 more versions of this crown and then try something. And we're going to take IPS e.max LT. So this is the low translucency version of e.max, whereas Impulse is definitely more translucent. And I put 2 like stump shade clay materials in here. So you can see we have the yellow one for kind of representing that same type of cement color, and then a little darker one to kind of represent if we had maybe an endodontically treated tooth or just a dark stump. And in the LT, the low translucency, you really don't see much of a difference between the two. This is still e.max, just like that first crown. It's just not as translucent as that first crown because it's the LT, the low translucency. This is the original e.max that we started using in the laboratory back in 2007. And there's a case online at glidewelldental.com where I actually have 4 e.max crowns, LT, the low translucency, on top of 4 metal posts and cores, and you cannot see them through the e.max at all. But keep in mind they were properly reduced, they were adequately reduced so that we had enough room. If I would have tried that with these LT crowns, then I would have had 6 or 7/10 thickness on the facial surface. I'm pretty sure that they would have shown through. I'm not sure if you see maybe a little yellow showing through on this one. Again, this is the same exact crown from the same file that was milled, but it's tough to, so again, this is the LT, but it's at a very thin dimension, and I do now think I see some of the yellow showing through there. Maybe not so much with the brown over on this side. In fact, this one looks to be a lower value than that one does, but they're identical crowns, exactly the same as that first one that had the yellow cement on the inside of it. And so if you've got a dark stump shade or you prefer to use a cement or bonding in with something that's not translucent, letting your lab know will give them an indication about, okay, maybe we should use the LT, the low translucency, or maybe they'll use the HT, the high translucency, or the Impulse, but they'll do some internal opaquing on the inside of the crown to keep that from showing through. So there's definitely ways to deal with it if you give your lab a heads up. And then I thought, I wonder what it would look like if we did it with zirconia. So again, with that same CAD/CAM file, we milled 2 more crowns, and these are BruxZir, and with the brown and the yellow on the inside of it. And zirconia, full contour zirconia, is still not as translucent as e.max, and so you'll see you don't really see a hint of the yellow there at all on this one. And as we look at the brown as well, I don't really see any show through, and you wouldn't expect to because it's not as translucent a material as the e.max, and you probably get that feeling, you know, even as you look at it and say, yeah, it doesn't seem like it looks as, you know, as tooth-like as the last crowns that we looked at, the e.max crowns. And so that's another way to be able to do this. In fact, the one reason where I go to e.max veneers, BruxZir veneers, I should say, for example, is on a deep tetracycline case. You know, the problem with tetracycline cases is as you try to prep more in order to get a thicker veneer, you get down to the darker color into the dentin. And so I've started to do tetracycline cases essentially as no prep veneers, only removing tooth structure where I need to achieve ideal arch form. And putting zirconia on top of that blocks it out much better than almost anything else. So it's not as translucent as e.max, and so you're not going to see as much. But even though it's not as translucent, a full 31% of the anterior crowns that we did last year for doctors were BruxZir crowns, but that's mainly for the strength more than anything else, because you've got something here that's virtually indestructible. In fact, when you look through remake rates here at the laboratory, you're not going to see a lot of fractures of e.max in the anterior either, just because we don't have those same biting forces there. So, whether it's the solid zirconia or it's the LT, the low translucency version of e.max, that'll keep it from showing through. There's a couple different approaches, and then the one where it's the Impulse or the higher translucency version of the e.max is where we can see really that outline of that prep kind of showing through there. And that's a good time to let your lab know either, I've got a cement that I want to use that's not translucent, or I've got a dark stump shade here. You can take a photograph. Ivoclar makes a stump shade guide if you don't have one of those. But typically a photograph just next to like an A3.5 shade guide will give the lab enough of an idea so that you don't end up being able to see the preparation through there. And of course, if you use that reverse prep method that I like so much, now you're using depth cuts and assuring that you're going to have at least 1 millimeter, maybe 1.2 millimeters of reduction on that facial surface, and then nothing will be able to show through. It's nice to see you. How are you doing today?
Good, Mike. Doing great.
Well, I love speaking with you because I find it inspirational, I find it informative, and I find it to really get at the core of some essential truths, some knowledge that dentists need to have. And I like it because I don't possess this knowledge. So I get to come to you and I get to get help for dentists on areas that have nothing to do with clinical quality, nothing to do with preparations, nothing to do with impressions, the stuff that I think is almost easier in a way because you can see it and touch it. But when it comes to doctors being satisfied with what they do, or just the opportunity to do that crown and bridge,
sure,
you know, something has to happen for a doctor to be able to do crown and bridge on a patient. And that is, he needs to be able to tell the patient about the treatment, and the patient has to say yes to the treatment.
That's a big step, isn't it?
The patient needs to be confident enough to walk in and say, drill me. And I'm always shocked when a new patient comes in and we meet them and we do a financial arrangement for a broken cusp they have, and literally 10 minutes later, I'm sticking them with a needle and drilling them. It's a huge amount of trust, and I know it's something that dentists struggle with, and they feel like, boy, if our patients just knew what we knew, they'd say yes to all this stuff, and that may or may not be true. But when patients say yes, there's a great feeling in the office. You get to do the quality dentistry you were trained to do, and everything just kind of seems to start to fall into place. So that's what I wanted to talk about today, is a little bit about what dentists can do and what dentists need to know to help their patients be able to say yes.
Well, you know, in dentistry, it all starts with case acceptance, Mike. I mean, that's the first domino to fall to make the dental laboratory industry run, the dental supply industry, the dental schools. Patient acceptance, case acceptance is really at the heart. And dentists, as you know, are so much in the culture of working with their hands, producing clinical dentistry, that when you get out of that silo and start talking about people and relationships, people get a little bit uncomfortable. I think a lot of dentists would think that dentistry would be a lot easier if it wasn't for the people.
Exactly. If we could just work on type-it-ons like we did in dental school.
Just work on the teeth, it would be fine.
Or what about the dentist who says, I went into dentistry because I didn't want to go into sales. I didn't want to be an insurance salesman, and now you're telling me I have to sell a case.
Well, you know, it isn't that I'm telling them. What it does is the patients expect to have a relationship. And the biggest break for me came in dentistry is when I stopped looking at case acceptance as a transaction and started looking at it as a relationship. And relationships it's not about being nice. It's, you know, when you say build a relationship with a patient, a lot of dentists would think, well, I am nice to patients. Well, it goes beyond nice. And I want you to think about relationship as just another way of being smart about the diagnostic process. Mike, we look at teeth, we look at gums, we look at occlusion, and we can analyze that and we can understand it. Dentists have got systems for things. If you're going to prep a tooth, you're going to need anesthetic, you're going to need impression cord, and you'll lay it all out. And if you do it enough and long enough, after a while you get into a rhythm, you develop a process. Dentists are really good about developing processes for technical events. In the event of a dentist assistant leaves or there's a change of personnel, you still have that process in place. So you can change people. But now, when it comes to the soft skills in dentistry, like case acceptance, if we can call it a soft skill or a non-clinical skill, very few dentists have processes in place that aren't people dependent. Well, case acceptance was real high for me when Ginger worked at the front desk, but now that she's gone, everything's gone to hell, and things have come apart. So what I did was I started thinking about what are repeatable processes that will outlive changes in your team. Changes in your team, Mike, are inevitable.
Right.
And we go to continuing education classes. You know how it is. You sit in a lecture, you get all juiced up, and you say, wow, I really like this practice management idea. But you go back in your practice and you try to implement it, and what happens? you always kind of regress to the mean. You always kind of regress back to how you used to do things.
Well, the staff wasn't there, perhaps,
Right.
to hear the message in person. And now the dentist is going to go back and translate what you said in his own bubbly way.
It
may
work.
kill it on his own and tell the staff about it. And they're going, just give him a week. Well, he'll get over this. Things will get back to normal around here.
Sure, the dentist comes back filled with the Holy Spirit. He says, everything's going to change here, and the staff, you know. So anyway, what I developed is an in-office, self-paced learning program around the topic of case acceptance. I've created a process, and this is the key deal. In the absence of a process, step 1, step 2, step 3, step 4, with applicable tools, that is paperwork that supports the process. In the absence of a process, Mike, you can't lead. You can't influence people because you have no way of going back and measuring, was the process followed?
Right.
If you're prepping a tooth and the assistant hands you the wrong instrument, you can give that assistant immediate feedback. Hey, you broke the process. Well, in the absence of a process of case acceptance, if we don't have a process, you don't know when the process isn't being followed.
Right.
There is no process. It's based on personality.
It's case presentation strikes me as seat of the pants as it gets in dentistry. I mean, there's not a lot of training. The dentist compensates for lack of comfort in the process by throwing out a myriad of technical terms designed to impress and educate the patient, marginal ridges, enamel rods, and all these kinds of things. But in reality, you're right. There is no checklist. You don't know when you're done. You don't know if you've done it right.
You don't know when you're done.
Right.
I guess when the patient says yes or no, that's when you're done.
And they stop you. That's enough.
And case presentation for most dentists is just an explanation of the treatment process. Well, Mike, the first thing we're going to do is get your gums healthy. Second thing we're going to do is this. Third thing we're going to do is that. Now, does that coincide with what I call influence? You see, dentists confuse education and influence. Education is the process that we use to raise patients' dental IQ. We have a medical legal responsibility to make sure that the patient goes through proper levels of informed consent.
Right.
But there's a big difference between consent and influence. Now, how much did you study influence in dental school, Mike?
I remember we spent 13 minutes on orthodontics, and I think we spent even less on influence.
Exactly
I'll
right.
put it at 0 minutes.
Sure, 0 minutes. And you read the journals. On the plane right out here, I was reading the AACD journal. All these beautiful cases. But nowhere is there a description of how was the patient influenced to make a good healthcare decision. That's what I set out to do and create a process around it. And I call it Yes Online.
Okay.
What Yes Online is, again, it's an online and DVD. Whatever's online is also duplicated in DVD. So dentists who don't have high-speed connections in their office and home still can learn it off the DVD. It's a self-paced program that the dentist, whether he or she would lead it to their team or have someone on the team lead it to the rest of the team. It's a division of DVDs and workbooks that takes the dentist and the team through a step-by-step process of developing a relationship with the patient and influencing that patient to make good healthcare decisions.
That's a great idea because I've seen this particular lecture that you give before, and it's a fantastic lecture, and I love the idea of being able to go home and do homework related around this, because I think it's difficult sometimes to take things that you've learned, as good as the ideas may be, and then to go back to your office on your own and try to implement those. It's one thing if it's a clinical thing and I say, hey, try this burr.
Right.
All that takes is the dentist to pick up the handpiece, stick a new burr, and try this.
And away you go.
But we're talking about team stuff here, and that takes a leader, and that seems difficult. So I love the idea of them being able to go home and follow up module by module and do it when it's convenient for them in their own
office. Well, you hit
office.
it on the head when you said it's easier when there's a burr involved. It's easier when there's a tool involved, Mike. If I say use this articulator, well, you can go out and use the articulator. And what an articulator will do, it will change the behavior of the dentist. The dentist, well, if I got an articulator, that means I need to take a bite, means I need to take a face bone, means I need to take study models. And so the tool changes the behavior.
Right.
Well, what tools have we had for case acceptance? Well, we really haven't had any. We've had visual aids, we've had study models, but oftentimes when you show a patient a study model or one of these plastic typodonts that shows a different type of thing, you end up in a clinical lecture with the patient. And that's not an influencing conversation. What we need are tools that are forms or different communication devices, conversations, essential conversations, I'll call them,
Okay.
that change behavior. For example, if I gave you a form and said, Mike, at the end of your new patient interview, you need to discover the 4 chiefs. The 4 chiefs is part of the Yes Online program. There's chief condition, which of course is the biological entity that's outside of normal limits. That's the broken tooth or the missing tooth. The second chief I want you to discover, Mike, is chief disability. See, dentists confuse condition and disability all the time. What disability is the patient's emotional reaction to the condition. For example, the condition might be I may have discolored composites between my front teeth.
Right.
The disability associated with that might be that I'm embarrassed when I talk to customers.
Right.
So the condition is in the mouth, the disability is in the life. Well, understanding disability is extremely important. It's one of the 4 chiefs. So the first chief is chief condition, second chief is chief disability. Third chief would be chief fit issue, fit, F-I-T. Fit means, what are your life circumstances? What is your budget? What is going on in your life right now that may get in the way of a treatment plan? It could be you're planning a vacation with your family, or your triplets, Huey, Dewey, and Louie, are in college now,
Right.
or you're remodeling your house. Those life circumstances that will impact your ability to accept care. Those are called fit issues.
Okay.
The 4th chief is what I call chief benefit. Once you understand the disability, then you automatically understand the benefit of treatment. So, for example, if your disability is you're embarrassed with customers, then the chief benefit is the opposite of that, or you're looking for confidence with customers.
So I don't have to put my hand up when I smile anymore because
exactly
I've got
right.
these ugly interproximal
Now,
deposits.
if I gave you a tool, remember we were talking about tools. If I gave you a tool that says at the end of your new patient interview, you need to fill out this tool, completing the answer to what are the patient's 4 chiefs. Now, at the end of the day, I collect all these forms, right, that you're supposed to fill out, or the assistant fills out. It doesn't have
Okay.
to be the doctor. It could be a staff
Even
member.
better, even better.
Even better.
Okay.
There you go.
It might actually get done now.
That's right. And then I look at the form, and you know what? Half of them aren't filled out. The tool hasn't been used. It'd be like if the hygienist wasn't using her scaler.
Right.
The tool wasn't used. See, so the tool now becomes a signal as to whether the process was followed.
Right.
So once you have that tool in place, now the behavior around it changes. The use of that tool now becomes subject to job and salary review. So the tool actually becomes a leadership tool. Does that make sense?
That absolutely makes sense.
Yeah. So the case acceptance process in Yes Online really starts with understanding what the patient's 4 chiefs are. We do a short piece on how to begin to discover that on the telephone, because the telephone really is the initial front door that
Right.
people walk through. What we don't learn on the phone, because you can't learn all the 4 chiefs on the phone, what we don't learn on the phone, you can learn in the new patient interview. So the 4 chiefs are understood prior to us looking in the patient's mouth. You see, a big focus of Yes Online is not so much educating patients, Mike, but rather understanding them. This is a big split. This is a big difference in the culture of dentistry. In our culture, we have a lot of training and a lot of encouragement to educate patients. As a matter of fact, there are insurance codes for patient education, isn't there?
Wow. Well, if there is, I never used it, but I always questioned how successful we were at educating patients, because I think that I communicate pretty well with people and pretty well with patients. And I've just had my own experience where I went through what I thought was a pretty lucid explanation of what we needed to do. And I'd walk out of the room and stand there and listen, and they'd turn to my dental assistant and say, "What did he say?"
What did he say?
And so it's
Yeah.
like, oh, great, I confused the patients. And confused patients probably don't say yes very often.
No,
Nobody does.
yeah, anybody that's confused, if you're confused about a purchase, let's say, of a television camera or a car, if you're confused, are you going to make a buying decision?
No, you're scared.
No, you're not.
Go home, do it another day, think it over.
So educating patients, number one, but it's in our culture, so we
Right.
think we're doing it.
Right.
Now, let me ask you this. The 4 chiefs is not about educating people. Understanding the 4 chiefs is about understanding someone.
Right.
All right. What's the insurance code, Mike, for understanding a patient?
I don't think it exists.
It doesn't exist. You see, it's not in the culture. Now, if you look at psychiatry, right, you look at that culture, there's codes for understanding patients there, isn't there? You see, it's just a matter of, it is what we say it is.
Right.
And really the first premise of Yes Online is how to discover what patients aren't telling you.
And as you gain this understanding of the patient, I'm guessing that this is the beginning of the relationship that you alluded to.
It's the heart of the relationship.
Whether you're dating or whether you're with a patient, this is how relationships happen between
this
people.
This is how people relate to
Right.
each other, because you understand something that's beyond the teeth. You see, dentistry is less about the teeth and it's more about the person.
Right.
I think when the dentist is in the first, when he or she is in the first few years, it's about the teeth, because you want to get confident with the mouth, you want to build up your speed, you want to get more experience with different restorative materials. But after you fix the tooth for a couple of years, doesn't the thrill of fixing the tooth begin to go away?
It does. It's just not quite the same as it was. It's not that exciting anymore. It's not, wow, I did it.
Yeah.
You know.
And you know, and a dentist's success will, you know, in year one, they're here in their practice in terms of their relative success, their fulfillment and joy, and then in year 2 and 3, they begin to continue to go up, and they get happier and happier. But you typically, I find about year 8 or 10, that their success, the feeling of success begins to plateau off.
Right.
You know, in the first era, the first, let's say, 5 to 8 years of a dentist's career really is fueled by acquisition of clinical skills,
Right.
Getting more speed in the mouth, getting more confident, getting a little bit more
Learning the things you didn't learn in dental school, whether it's porcelain veneers or whatever.
Dealing with the team, dealing
Right.
with your facility. However, a practice will plateau off at 8 to 10 years if you rely strictly on your clinical skills. At some point, people skills or relationship skills need to kick in.
You know, it's funny you mentioned that because my father was a dentist and my dad was great at relationships. Now, he didn't have your system. He just was a really genuine guy who truly enjoyed the people part of the business. And I remember at his retirement party, so many patients, and even people I run into today will say, your dad was just the greatest dentist.
Yeah.
And I know for a fact he gave the most painful injections that I ever saw. He would levitate people a good foot out of the chair, just stiff as a board, as he emptied a carpule in about a second.
Yeah.
And I used to think, wow, this gives me an in if I give a painless injection, but they were still so connected to him, and it was all about that relationship. And he could have told them, if they had an abscess, you need a root canal, or he could have said, stand on your head for an hour in that corner, and they probably would have done it because of that relationship. So I've seen that firsthand, but I think it's a very rare dentist like my father who's able to do that without even trying. And, and I think this system's going to show other dentists how to get that same type of connection.
A guy like your dad could do the exam in the car. Right?
Right, exactly.
The patient would have loved it.
Right.
And you see, that's personality based, and there's some of us who are blessed with that.
Right.
However, most dentists aren't dentists because they've got these great gregarious personalities.
Right.
The really great dentists are more technically oriented, very cognitively driven. The domain of expertise is this kinesthetic and the cognitive intelligence. And interpersonal domain intelligence, or affective domain, how another person feels in their presence, oftentimes we're not even aware that it's out there. So
that was an elegant way of saying that geeks and nerds go into
exactly
dentistry.
Right. Exactly right.
And so, yeah, if you don't have that and it turns out to be such an essential component of success, why not train for that like you would for training for veneers or molar root canals?
Right. And what drives that is a process.
Right.
So the process of case acceptance really starts by understanding what the patient's 4 chiefs are and getting a handle on what is it that people typically don't tell you. Typically what people don't tell dentists is how the condition interferes in their life.
Right.
You know, I have a friend, his name is John Gordon, and John is a great cosmetic dentist. I was in his consultation room. He's talking to a young Asian woman, delightful woman, and she's complaining about her anterior front teeth. Large diastemas, I don't like this space, I don't like this space, I don't like this space. And John's a student of mine, and what he's listening for, what he was hearing, was her condition.
Right.
And what John did is he went from condition to understanding the patient's disability. He asked her this great question. This is what we teach in the Yes Online material. He asks, well, tell me about a time when it bothered you the most. Or another great question that's similar to that is, tell me about the time when you first began to notice this problem. The woman says, well, I can tell you when it bothered me the most. I'm sitting at my desk, a group of coworkers was talking, they burst out laughing, and one of them looked at me, And I know they were laughing at me. And when she said that, Mike, a big tear rolled down her cheek. Well, what Mike heard was her disability, and he voiced it back to her. He said, well, it sounds like you're ashamed of your appearance. She says, that's exactly what I am. And then, hearing the disability, he used the disability as the motive for moving forward to the next step. He said, well, let's do this then. Let me put you in the operatory and let's see if we can get you your dignity back. Now, just think about that for a minute. He went from condition to disability, then to chief benefit. Chief condition, chief disability, chief benefit. Now, what's a greater platform for this woman to accept care? Her understanding the process for laminate veneers. He could have opened the drawer and said, stop your crying, here, let me show you how we can fix your teeth.
Right.
Right? Or is a stronger platform the promise of restoring this woman's dignity?
That's what it's all about to her anyway. He just listened
He
and vocalized it.
That's right.
And there's empathy there because finally, and it may not even occur to her, but he gets me.
That's right.
He knows how I feel about
Now,
this.
in the hustle and bustle of the dental work, this is the manual that's available
Okay.
with Yes Online. In what's all that's going on in the dental office, let me flip to the page here. This is just some example of the work. With all that's going on in the dental office, it might be easy to forget about the 4 chiefs. But if you had the tool to remind you, if you've got the tool of recording the 4 chiefs during your new patient interview, then it's duplicatable. Then you're reminded to do it and it won't slip through the cracks. Second thing that's going to happen is that once you have the patient in the chair, you have to understand what bothers the patient and what bothers you.
Right.
You know, oftentimes we look at a mouthful of broken amalgams and we cringe. And we immediately jump to the conclusion, well, if it bothers me, it probably bothers the patient too.
Well, I'll educate him into being bothered.
I'll educate him into
when
being
I tell you what's
bothered
wrong
about
with
it.
your teeth, you're going to hate them just like I do.
Well, we have another tool called the Discovery Guide. And the Discovery Guide is a sort of a map. It's a sort of a map in the sense that you would identify what conditions the patient is aware of and what conditions bother the patient. And if you take the 2 variables of awareness, are they aware of the condition? Yes or no. And are they bothered by the condition? Yes or no. You end up with 4 different situations.
Right.
Well,
Because that's a big deal, being aware of it or not, right?
that's a very big deal.
I mean, because it's enough of a shock to find out you have something, let alone be thrown the treatment at the same time. It's a big difference between somebody who's missing a tooth because it was knocked out here and they know the problem exists, and somebody who went to a dentist in St. Louis, for example, for 15 years. Now they moved to California, and this is the first they're hearing of it, and it's shocking them because
you've got an open
8
margin
teeth.
down here,
Right.
and you've had it for a while. Well, how come my previous dentist didn't tell me? And then you get into that contest.
Right.
All about that.
My thanks to Paul for spending some time with us, and whether you take his case acceptance for Everyday Dentistry Workshop or his public speaking course, which I love the title of, it's called Just Because an Expert Doesn't Make You Interesting. Either one of these is going to help your communication skills with your staff, with your patients, if you go out and do lectures, or even, like I said, with your kids at home. So look into those. Go to paulhomoly.com and you can check out any of those courses. So thanks to him again for being here. You'll see part 2 of that interview in a future episode of Chairside Live. So on behalf of myself, everyone here at the lab, and the CSL crew, I want to thank you for your time and your continued commitment to quality dentistry.